Imagine leaving a clinic after a quick 5-minute cosmetic enhancement on a Tuesday afternoon.
Right, just a standard lunchtime appointment.
Exactly. You're told it's a minor outpatient procedure.
Yeah.
You expect a little swelling, maybe some mild discomfort, but nothing serious.
Yeah, you're definitely not expecting a crisis.
But then fast forward 24 hours, and you are suddenly facing a full-blown medical emergency. I mean, complete with catheters, ultrasounds, and specialist interventions.
All because your body has suddenly and completely forgotten how to perform one of its most basic, essential functions.
It is wild. Welcome to the deep dive. Today, we are exploring a very specific, incredibly intense medical scenario.
It's really the ultimate collision between elective aesthetics and emergency urology.
Yeah, you go in for a minor tweak, and you end up navigating a highly specialized trauma response. So our mission today is to map out the exact clinical protocol for what happens when a patient develops acute urinary retention in the first 24 hours following a G-spot injection.
Right. And understanding this protocol is, well, it's a brilliant exercise in medical critical thinking for you, the listener.
Because it really strips away the polished marketing, right?
Exactly. It strips away the whole lunchtime procedure facade and forces us to look at the raw underlying physiology. We're looking at how clinicians build a safety net to bridge a cosmetic intervention with a rapid emergency response.
So to understand the emergency protocol for a blockage, I feel like we have to start at the physical root of the problem. Like, what is actually being injected? Where is it going? And how does it mechanically disrupt the body?
Right, you have to look at the anatomy. The procedure we're talking about is a G-spot augmentation.
Commonly known as the G-shot, right?
Yeah, the G-shot. So a clinician takes a hyaluronic acid filler, usually a dense, highly viscous product from like the Juvederma Restylane families,
Right.
and they inject it directly into the anterior vaginal wall. Specifically, they're targeting the Grafenberg zone, which sits about 2 to 3 centimeters in from the urethral meatus.
And the whole objective there is to deposit enough filler to create a physical projection, right? Like a localized mound, maybe the width of a quarter, just to enhance physical sensitivity.
And that's the goal. But the problem lies entirely in the real estate of that specific anatomical zone.
It's pretty crowded in there.
It is incredibly compact. The area we're talking about isn't some cavernous empty space. The anterior wall of the vagina and the posterior wall of the urethra share the exact same fascial plane.
Oh, okay, so they're basically fused.
Yes, it's known as the urethrovaginal septum. And it's a densely packed layer of connective tissue and smooth muscle.
So when you inject a highly viscous gel like hyaluronic acid into that septum, that fluid has to displace native tissue to make room for itself, right?
Exactly. It has to push things out of the way.
Okay, let's unpack this with a visual. It's like placing a localized speed bump on a narrow road to slow traffic down.
That's a good way to look at it.
But if you make that speed bump too tall, or if the construction crew shifts it just a fraction of an inch into the adjacent lane, you don't just slow down the traffic, you create an impassable barricade.
Right. And in this case, the traffic is urine.
Yeah.
And it comes to a complete, total halt.
Which is terrifying.
That analogy captures the mechanics perfectly, though, because the urethrovaginal septum lacks vast elasticity. It cannot stretch endlessly outward.
So it has nowhere to go.
Right. So if the hyaluronic acid is deposited too deeply into the periurethral smooth muscle, or, if the clinician miscalculates the tissue planes by even a millimeter.
Just a millimeter.
Yeah, just a tiny bit. The sheer volume of that filler acts like a clamp. It pushes inward against the path of least resistance, which just happens to be the soft, hollow tube of the urethra.
And that physical mechanical compression pinches the urethra shut, which leads directly to acute urinary retention, or AUR. I hear that, and my immediate thought is, how common is this nightmare scenario? Because we're talking about a procedure that's marketed globally as a quick, routine outpatient appointment.
Well, when performed by a practitioner with a deep, masterful understanding of pelvic floor tissue planes, severe mechanical complications like acute retention are statistically rare.
Okay, that's reassuring.
But we have to separate rare from impossible.
Yeah.
I mean, the margin for error here is microscopic.
Because the space is so tight.
Right. A slight miscalculation in needle depth or injecting just maybe 0.5 milliliters too much filler for a specific patient's unique anatomical capacity.
Wow, half a milliliter can do that.
Yeah, that's all it takes to turn a lunchtime appointment into an organ-threatening event. And that precise volatility is why this strict postoperative protocol was developed in the first place.
Which brings us to identifying the red flags, because The clock really starts ticking the moment the patient leaves the clinic.
Absolutely. In that crucial first 24-hour window, spotting the blockage before irreversible damage occurs to the bladder is the absolute priority.
Now, a total blockage seems like it would be impossible to miss. I mean, the clinical signs of acute urinary retention are pretty aggressive.
They are very aggressive.
We're talking about significant, sharp lower abdominal or suprapubic pain, visible, hard swelling in the lower abdomen, plus a desperate, agonizing urge to urinate, coupled with an absolute physical inability to release a single drop.
The total blockage is agonizing, yes, but it's actually the easier scenario to diagnose.
Oh, because the patient knows immediately that something is wrong.
Exactly. What's fascinating here is that what clinicians are really highly trained to look out for in this protocol is what we call covert retention.
Covert, so like a hidden blockage.
Yeah. Sometimes the filler doesn't clamp the urethra shut 100%. It might pinch it, say, 90% closed. In these cases, the bladder fills up, stretches to its absolute maximum capacity, and the sheer mechanical pressure forces a tiny amount of urine past the blockage.
Oh, I see. Like a dam overflowing.
Precisely like a dam overflowing.
Yeah.
The patient might experience small, frequent voids, usually passing under 150 or 200 milliliters at a time.
So they feel the urge, they go to the bathroom, they hear liquid hitting the bowl, and they think, oh, the plumbing is working.
Right, but those small overflow voids completely mask the fact that the bladder itself is retaining a massive, dangerous volume of fluid.
That is so deceptive.
It is, which is why the clinical protocol explicitly mandates that a physician cannot rely on a patient's subjective feeling of having successfully emptied their bladder.
So you can't just ask the patient, did you pee today? And check a box.
No, absolutely not.
But here is where I get tripped up on the diagnostic side of things. It's completely normal for there to be temporary tissue swelling, inflammation, hypersensitivity in the pelvic region for the first 48 hours after injecting a foreign substance like filler.
Yes, very normal.
So how does a clinician in an emergency setting look at a swollen, uncomfortable patient and distinguish between standard, expected postoperative inflammation and this dangerous covert retention?
They remove guesswork from the equation entirely through objective measurement. The gold standard diagnostic tool in this protocol is the portable bladder ultrasound.
Like a bladder scanner.
Exactly, bladder scanner.
Yeah.
It uses high-frequency sound waves to penetrate the abdominal wall and bounce off the fluid inside the bladder, which calculates the exact volume of liquid present in real time.
Oh, wow. So they can see exactly what's in there.
Yep. So the clinician instructs the patient to go to the bathroom and attempt to empty their bladder completely. And immediately after the patient finishes, they run the scanner over the suprapubic area to measure the post-void residual volume, the PVR.
So they are measuring exactly what was left behind rather than what actually came out.
Yes. And the diagnostic threshold is very strict. If the ultrasound reveals a residual volume greater than 150 to 200 milliliters of urine still trapped in the bladder after a concerted attempt to void, acute urinary retention is definitively diagnosed.
Wow. So it doesn't matter if the patient feels perfectly empty, the scan proves the anatomical pathway is critically obstructed.
Exactly. Data over feelings in this case.
Okay, so once that scanner flashes a high number, the protocol shifts violently from assessment to immediate intervention. I mean, if that post-void residual is sitting at 300, 400, or 500 milliliters, the very first step of the protocol is rapid bladder decompression, right?
It has to be. The clinician has to establish an artificial pathway and drain that trapped urine immediately.
Because leaving it in there is just too dangerous.
Right. Decompression is non-negotiable. And it's entirely about protecting the cellular integrity of the bladder wall. You see, the bladder is a hollow organ made primarily of a specialized smooth muscle called the detrusor muscle.
Okay, detrusor muscle.
And this muscle is incredibly elastic. It's designed to stretch and hold fluid and then contract forcefully to expel it. But if the bladder is subjected to severe overdistension, meaning it's stretched far beyond its natural capacity for an extended period, you start to tear the extracellular matrix holding those muscle fibers together.
Ouch. So it's like if you take a brand new rubber balloon, blow it up until it's nearly transparent, and leave it sitting on your counter for 3 days.
Right. Perfect analogy.
When you finally let the air out, it doesn't snap back into a tight little circle. It's all stretched out, wrinkled, and physically compromised.
Yeah, we are trying to prevent the bladder from permanently losing its elastic snap.
Right.
But clinically, it's even more severe than a stretched balloon. Extreme overdistension increases the pressure inside the bladder wall so much that it actually compresses the tiny blood vessels supplying oxygen to that detrusor muscle.
Oh no, so it cuts off the blood supply.
Yes, it causes localized ischemia tissue starvation. If those muscle fibers and the surrounding nerve endings are starved of oxygen for too long, they suffer permanent damage.
Which means the patient could face a lifetime of bladder dysfunction, all from a delayed response to a cosmetic injection.
Exactly, it's a huge risk.
That raises the stakes incredibly high. So, to prevent that ischemia, the protocol outlines two specific methods for decompression. First, the clinician might insert a short female Foley catheter, typically a size 12.
Right, which is a thin tube passed directly through the compressed urethra into the bladder, totally bypassing the filler blockage.
And then a small balloon is inflated inside the bladder to hold it in place, allowing the urine to drain continuously into a bag. That's an indwelling catheter.
Yes.
But the protocol strongly favors an alternative approach, right? Clean intermittent self-catheterization, or CISC.
Yeah, the preference for intermittent self-catheterization is deeply rooted in patient recovery monitoring. With an indwelling Foley catheter, the bladder is kept continuously empty.
Right, because it's just constantly draining.
Exactly. And because of that, the clinician has no idea if the internal swelling has gone down or if the filler has shifted, because the tube is doing all the work artificially.
That makes sense.
By teaching the patient how to perform self-catheterization, the patient gets to actively test their own system. Every few hours, they attempt to urinate naturally.
And if they can't, or if they only go a little bit, they just insert the catheter to drain the rest.
Right. This provides real-time, objective feedback on whether the anatomical pathway is naturally opening back up.
Okay, so we've bypassed the blockage with the catheter, protecting the bladder wall. But the protocol doesn't just stop at mechanical draining. It attacks the problem pharmacologically as well.
It does.
Alongside the physical decompression, the clinician will often prescribe selective alpha-adrenergic blockers. You're talking about oral medications, like tamsulosin or alfuzosin?
Yeah, this is where we look at the neuromuscular environment of the pelvic floor.
Hmm.
The smooth muscle surrounding the bladder neck and the proximal urethra is heavily populated with alpha-1 adrenergic receptors.
Okay.
Under normal circumstances, your sympathetic nervous system releases neurotransmitters like norepinephrine that bind to these receptors, causing those smooth muscles to contract and stay tight.
So this is what keeps you from just leaking urine throughout the day.
Exactly. It's the body's natural clamping mechanism.
But right now, in this scenario, we have a hyaluronic acid filler creating a massive physical clamp, plus all the localized tissue inflammation. So we have way too much clamping happening all at once.
Exactly. We need to override that nervous system signal. So when a patient takes an alpha blocker, the medication binds to those alpha-1 receptors and blocks the norepinephrine from attaching.
Ah, I see.
This forces the smooth muscle of the bladder neck and the periurethral glands to deeply relax. We are artificially dilating the pathway.
So by forcing the surrounding tissue to loosen its grip, we reduce the resistance the urine faces.
Right, giving the system the best possible mechanical advantage to push fluid past that compressed, filler-heavy area.
So for you, the listener, if you ever find yourself in this incredibly stressful scenario, you are not just handed a towel and told to wait for the swelling to go down.
No, absolutely not.
You are actively managed. Your bladder is mechanically protected from ischemic damage via catheterization, and your internal musculature is chemically manipulated via alpha blockers to create the widest possible exit route.
It's a very proactive protocol.
But here's where it gets really interesting. Catheters and alpha blockers treat the symptoms, right? They deal with the trapped urine and the tight muscles. But this specific protocol offers a highly unique, targeted way to treat the actual root cause of the blockage.
Yes, and it's a distinct advantage specific to the material used in the injection. Because the G-shot utilizes hyaluronic acid, clinicians have access to a specialized biochemical tool.
They have an enzyme called hyaluronidase.
Right.
If the bladder ultrasound shows that the urethral compression is severe and it isn't resolving with basic decompression, the protocol allows the clinician to draw up a syringe of hyaluronidase and inject it directly into the site of the original G-spot enhancement.
We really need to look at what's happening at a molecular level when that injection occurs. Hyaluronic acid is a massive polymer. It's a long chain of repeating sugar molecules linked together by specific chemical bonds called glycosidic bonds.
Okay, glycosidic bonds.
And that long tangled chain is what gives the filler its thick, viscous, gel-like property.
Right, which makes it a great filler.
Exactly. But when the clinician introduces hyaluronidase into that environment, the enzyme acts as a biochemical scissor. It specifically targets and cleaves those glycosidic bonds.
Wow, so it just aggressively chops that long chain into tiny fragments.
Yes, it depolymerizes the structure. Within a matter of hours, the thick, solid gel that was physically compressing the urethra is broken down into a thin, watery liquid that the body's lymphatic system can easily absorb and flush away.
That is wild. It's the ultimate chemical undo button.
It really is.
You don't have to go in surgically to scrape the filler out. You just melt the speed bump away while leaving the road intact. But I'm assuming it's not actually that simple. A chemical solvent that dissolves tissue can't possibly be a risk-free magic wand.
If we connect this to the bigger picture, it is certainly not a magic wand. The protocol actually includes severe warnings regarding its use.
I figured.
The danger lies in the fact that hyaluronidase is a non-selective enzyme. It is entirely incapable of distinguishing between the synthetic cross-linked hyaluronic acid in the dermal filler syringe and the endogenous natural hyaluronic acid that your body produces organically.
Oh, the stuff your body makes to keep your own cellular matrix plump and structured.
Exactly.
So it isn't a smart bomb program to only attack the foreign invader. It is a general solvent. If it touches natural hyaluronic acid, it chops those bonds up too.
That is the exact risk. If a clinician uses an excessive dose of the enzyme, or if they inject it too broadly across the tissue planes, they will degrade the patient's native structural tissue. The clinical literature refers to this as post-hyaluronidase syndrome. The enzyme dissolves the filler to relieve the compression, but it keeps going, dissolving the natural volume of the anterior vaginal wall.
So patients can be left with significant hollowing, structural atrophy, and severe changes to tissue elasticity.
Yes. They go in for an enhancement and leave with tissue that feels prematurely aged or deflated.
That is so tragic.
Which is why the protocol dictates that the dosing of this enzyme must be meticulously calculated. It's a high-stakes balancing act between dissolving just enough of the synthetic roadblock to save the bladder while preserving as much of the natural pelvic architecture as possible.
It's a terrifyingly thin line to walk. But let's look at the final phase of the protocol. Let's assume the clinician navigates that balance successfully.
Okay.
Whether they utilize the enzymatic undo button to dissolve the filler, or they simply relied on catheters and alpha blockers for a few days while the swelling naturally subsided, the patient cannot remain in medical limbo forever.
No, they can't.
Eventually, the protocol requires safely proving that the biological plumbing system works again.
Right. And the clinical milestone for this is universally known as the TWOC, the trial without catheter.
Now, the timing of the TWOC is interesting. It usually takes place within 1 to 3 days following the initial retention event. But if the patient's bladder was subjected to massive overdistension, say retaining over 1 liter of urine before they got to the ER, the protocol dictates waiting up to a full 7 days before attempting the trial.
And that extended timeline directly correlates to the cellular damage we discussed earlier.
The ischemia.
Exactly. If the detrusor muscle in the bladder wall was stretched to the point of ischemia, it needs significantly more time to repair its extracellular matrix and regain its contractility. You cannot force an exhausted, damaged muscle to perform.
Right, you have to wait for the biological snap to return.
Precisely.
So when the tissue is finally ready, the mechanics of the trial are highly standardized. The patient arrives at the clinic, usually first thing in the morning. The clinician deflates the balloon and completely removes the indwelling Foley catheter.
Yep.
The patient is instructed to drink a measured, moderate amount of fluids, and then they are put on a strict 4-hour countdown. Within those 4 hours, they must feel the urge and attempt to urinate naturally.
And it's a purely data-driven test. Subjective feelings of success just don't matter here.
The ultrasound comes back out.
Exactly. If the patient is able to naturally void within that 4-hour window, the clinician immediately brings out the portable bladder scanner again. They check the post-void residual. If the ultrasound confirms that there is less than 150 to 200 milliliters of urine remaining in the bladder, the patient passes the trial.
The anatomical pathway is officially clear.
Right. The detrusor muscle has recovered its tone, and the acute emergency has resolved.
But if they fail the test, if they sit there for 4 hours and cannot produce anything, or if they void a tiny amount but the ultrasound shows like 400 milliliters still trapped inside, the protocol is ruthless.
It has to be.
The Foley catheter goes immediately back in, or the patient resumes their self-catheterization routine at home. And at this stage, they are elevated beyond the initial emergency response and are officially referred to a urologist for long-term evaluation.
Right. Now, the anatomical reality is that most cases of acute retention following a G-shot do resolve as the filler integrates into the tissue and the reactive swelling dissipates.
That's good news.
It is. But if the retention drags on, if the patient is still relying on a catheter to empty their bladder beyond the 6-month mark, it crosses a clinical threshold.
It's no longer acute.
Exactly. It's officially classified as chronic urinary retention, requiring entirely different long-term urological management pathways.
Wow. Looking back at this entire journey, it fundamentally changes how you view a so-called minor cosmetic procedure.
It really does.
I mean, we've mapped out the physical realities of the urethrovaginal septum. We explored the mechanics of covert retention and why an ultrasound is mandatory to see past a patient's symptoms.
Right.
We broke down the cellular urgency of bladder decompression to prevent ischemic damage, the targeted neuromuscular relaxation of alpha blockers, and the high-stakes biochemical intervention of hyaluronidase, all leading to the final data-driven trial without a catheter.
There is a massive, highly sophisticated clinical safety net running in the background of elective medicine.
It's incredible.
It serves as a stark reminder that human anatomy demands absolute respect. The body's physiological pathways do not care if a localized obstruction is caused by a medical pathology or an elective aesthetic filler.
The body just reacts to the blockage.
Exactly. It only registers that a vital system has been blocked, and it cascades into failure accordingly.
Which leaves us with one final, incredibly important thing to consider. The entire safety net we discussed today hinges on one specific biochemical reality.
The undo button.
Right, the fact that hyaluronic acid can be dissolved. But the field of cosmetic gynecology is aggressively pushing forward. Clinicians are beginning to experiment with semi-permanent biostimulators for these intimate injections, synthetic materials like polylactic acid or calcium hydroxyapatite.
Yeah, that's becoming a major trend.
And these substances are designed to trigger massive collagen production and last for years. Crucially, they cannot be broken down by hyaluronidase. They cannot be melted away.
This raises an important question, and it's really the defining question for the future of this field.
Yeah.
As patients increasingly demand these permanent, indestructible fillers for intimate enhancements, the risk calculation changes fundamentally. When the biochemical undo button no longer exists, how will emergency urology adapt when the localized speed bump becomes a permanent concrete wall?
That is a thought that should make anyone pause and reconsider the true weight of elective procedures. We encourage you to keep questioning the protocols running quietly behind the scenes and to keep exploring the intense, unforgiving, and fascinating intersections of modern medicine. Until next time.